As two practicing physician assistants, we've seen a lot and we've heard a lot. We know that you've heard a lot too. We are here to help you navigate through the BS by having open and honest conversations with other practicing professionals. I'm Heidi.
And I'm Cassie, and welcome to Mindfully Woman.
Hello, everybody, and welcome back to an episode of Mindfully Woman. We have an exclusive episode today. We have our first male guest on, and we are so excited. His name is Brandon Boyd. He is a certified physician assistant. He currently practices in ENT and has a specialization in training in sleep medicine. So welcome to the podcast, Brandon.
Thank you for having me. And I'm extra honored finding out I'm the first male.
Yes. We have to keep the end of the name strong. You know, you got to keep the man part strong of the Mindfully Woman.
There you go. Can't have one without the other, right?
Exactly.
Yep, you're exactly right.
Exactly. So we want to know, about you. So tell us a little bit about yourself, how you got to where you are, anything that you want to share with us.
Yeah, absolutely. So I work in ENT, obviously, and that was not my intention when I started PA school. I really wanted to do neurosurgery. And then I met a neurosurgeon who asked if I like my family. And I said yes. And said, then you probably don't want to do neurosurgery. So
That's
my
harsh.
program, it's harsh but true.
Right.
So my program that I attended, ENT was a required rotation, a mandatory rotation. I just fell in love with it. And, I get to know a lot about this and kind of the rest is up to the other specialties like yourself.
Mm-hmm.
And then once I started working in ENT here in Indiana, just one of our surgeons, my mentor, Dr. Todd Huntley, who's now retired, he is a world-renowned sleep surgeon. And he just kind of drew my interest into it. And I realized how it's just phenomenal and amazing and interesting and constantly evolving. And one of those fields where you can make an immediate difference in someone's life just overnight, literally overnight. We're talking about sleep. And I just loved it. And I've kind of always had a love-hate relationship with sleep myself. So I've learned and grown myself as I've taught other people to learn and grow.
That's very cool. How long have you been doing sleep therapy?
So I've been working with this group for 10 years. And I'd say
Wow.
the last 8 to 9, I've been dealing with sleep. Insomnia really kind of kicked off in my practice about 5 years ago, and it's just exponentially grown since.
That's amazing.
Yeah, that's really, really cool.
Do you do a lot of sleep and ENT combo?
Yes, absolutely. I was originally hired purely to kind of man the cancer side of our practice, the head and neck cancer side. And then as I drifted more towards interest in the sleep, I kind of separated myself from that, handed over the reins to another PA, and just kind of started to dive right into sleep. And I just checked my numbers last night, our metrics, and 60% of my patients are now sleep medicine patients.
Wow.
That's amazing.
And 40% are general ENT. So I get a nice mix.
That is a good mix. And I feel like that's nice too. You've kind of found your niche, subsequently by meeting people, but that's how it all happens, right? You just find what you like. Yeah. So
fell into place. Absolutely.
Yeah. Are you the only one in your practice who does sleep medicine, or is there others now?
So historically, sleep apnea it's the only sleep condition that has a surgical fix or a potential for a surgical fix. So that's kind of where our sleep practice started. And so all of the ENTs have some training in basic sleep medicine as far as sleep apnea, the CPAP. All of our physicians and PAs can order sleep tests and prescribe CPAP, but it's gotten, to the point where I pretty much take over all of it. And if it's more than just a simple run of the mill CPAP patient, then I take them over and get them sleeping better.
Wow.
That's really cool.
Yeah, that's really, really neat.
To be honest with you, I guess maybe showing a little bit of my naiveness or ignorance a little bit. I guess I never knew there was enough ENT PAs out there that did sleep medicine, because in a previous job, we would refer a lot to we had a sleep medicine group, which I think notoriously practiced as pulmonologists sometimes. So
correct.
Yeah, that's really cool.
Yeah, and It's definitely it's growing. This is a perfect field for us as PAs, because it's with the exception of sleep surgery, it is all clinical medicine, which is what we're best at.
Mhm.
And as far as ENT and sleep, it is not a huge boom as far as the PA profession goes, but there is a growing number of ENT PAs that deal with sleep because, again, sleep patients get referred to ENT and ENT surgeons want to do surgery. And
Yeah.
we're not surgeons, so this is perfect for us.
Yeah.
Mhm.
Walk us through what a day in the life of you looks like, or a week,
So-
whatever you want to tell us.
So I've got a pretty cush schedule.
That's awesome.
It's evolved that way. I work Monday through Friday, 9 to 3. I work through lunches, do telemedicine. For patients, we have a lot of patients that live in the remote portions of the state that have to drive 2.5 hours, and that's kind of unreasonable for a CPAP download. So
Mhm.
I see, like I said, 60% of my patients are sleep. We are really big in the Inspire hypoglossal nerve stimulator treatment, the kind of the implant that stimulates the tongue, and I manage all of those patients, and that's kind of been taking over a lot of my non-insomnia portion of the practice, but it's a huge mix of patients. So I primarily treat adults because the first step, if you're referring to a child, would be to pediatric ENT or pediatric sleep medicine.
Mhm.
But I do have some kids that I treat for insomnia. We'll get into that in a little bit later, but sleep apnea in kids, which is a growing concern that we dramatically underestimated. And there's the puppy.
Yeah, here's
He's up.
mascot.
So it's about a 50-50 mix in our practice of kind of clinical management versus surgical management.
Okay.
I have some patients that are cancer follow-ups I've been following the whole 10 years I've been there. Kids that I've been following for 10 years that are now teenagers, and it's
Oh,
amazing to see.
wow.
Yeah, I get a little bit of everything.
Okay.
That's really cool. Tell me more about that stimulator, because I don't
Yeah.
know much about that at all, Ross.
So it's there's only one FDA approved hypoglossal nerve stimulator. It's branded as Inspire. If you Google it, like through St. Vincent, it'll come up as hypoglossal nerve stimulator. But it is a pacemaker device implanted in the right chest. Leave the left side for the heart if you need a heart pacemaker.
Mhm.
But there's an electrode lead that is connected to the hypoglossal nerve, which is your tongue movement nerve. And whenever you breathe in, it stimulates the tongue to push forward a little bit using low voltage and opening up the airway in front to back fashion. Both of you push them out of the way at the same time. But it is the most, as far as the standard surgeries go, the most effective surgical option for sleep apnea that we have, and by far the safest and well-tolerated option.
That's
Wow.
awesome.
So, how often do you have to see them after that is implanted?
So we do the standard post-op, incision check. 1 month after, we turn their device on,
Oh,
find
wow.
their initial settings, and then we see them back every 6 weeks until we're ready to test them. And then where they're sleeping comfortably through the night, all night with therapy, feel better. We do a home sleep test. If they're better, that's where they stay. If not, then we continue making changes every 6 weeks until we test again. And then once they're fully titrated, we see them back twice a year. And that's mostly just make sure that they objectively are still better, but
Mhm.
also to make sure that the battery remains in good standing.
Wow. So, how long do those typically
gonna ask
last
that, yeah.
then?
Yeah, so estimated 11 years. We did our
Wow.
first Inspire implant. We were the first in the state, one of the first commercial implanters in the country. And it was in November of 2014. So we're coming up on that 11-year mark. So we anticipate needing to do
Okay.
it soon, but haven't
Yeah.
had to do any replacements yet.
That's awesome that you haven't had to do any yet. That's really
Yeah.
cool.
Yeah.
11 years,
Yeah.
that's a long time.
Yeah. I had never heard of this before. That's
Oh,
so
really?
cool. Yeah. I
The
haven't
more
heard
you
much
know.
about it.
Yeah.
Yeah.
I have somebody from my hometown that got one and was like raving about it on Facebook. So that's the only reason why I know it. But I think don't you have to go through like a whole trial with the CPAP and everything too first for like insurance to cover it? Like it's a
Absolutely.
process.
Yeah, absolutely. It's so surgical management, really in medicine, period, sleep medicine's no different. Surgical management is not first line, except for life-saving treatments. So ethically and by FDA labeling, we need to try conservative measures first, which is CPAP or oral appliance for the right candidate. And CPAP is by far the most effective and safest treatment if you can tolerate it, which is not always easy.
Yeah.
Studies say up to 60% of people can't tolerate CPAP. So
Wow.
there's definitely a
60%?
need for alternatives. Yeah, 60%.
That's a lot higher than I would expect.
Yeah, I was going to say I worked in family medicine for a hot minute, and it was, I mean, most notoriously people didn't like them or use them how they should use them because it just didn't work the way they wanted it to, or they hated wearing them or whatever.
Yeah, and that's a very common issue, obviously. So we kind of like to set ourselves apart from, the standard run-of-the-mill practices. I don't want to say everybody's run-of-the-mill. I'm saying people that don't specialize in CPAP. Everybody's great. It's just you don't have specialty training in it. And I tell patients, expectation management, of course, is important, but there is a solution for nearly every complaint about CPAP, as long as they voice their concern and then, work with me for it. So I've been dealing with CPAP patients a lot. I've led several courses to APPs to learn how to manage sleep apnea and CPAP and make the tweaks and adjustments and what are the solutions to all those problems. And we have a very high compliance rate in our group. We're about 98% compliant, which is leaps and bounds above the national average.
Wow, that's great.
Yeah. Yeah, that's really impressive. And I'm sure hard to do.
Yeah.
Not easy always, that's for sure.
But when you have the right training and when you then know how to tell other providers how to do it the best way, it helps with your success rates too. So
absolutely.
That's awesome. What's the most common diagnosis that you see then? Is it insomnia?
So sleep apnea is the most common, obstructive sleep apnea, and that's the most common diagnosis we see because it's statistically the most common sleep disorder. But it is also, again, historically, ENT has been able to manage sleep apnea. So we get a lot of direct referrals directly for that purpose. But the vast majority of people with one sleep disorder have more than one sleep disorder. So then I end up wrapping them up into, managing restless leg or insomnia or circadian rhythm disorders, whatever it may be. So kind of a one-stop shop.
Yeah.
That's awesome. What's your most typical approach to somebody that's struggling with sleep? How do you go about that? I guess that's kind of a tricky question because it depends on what they're coming to you for. But I guess if somebody was coming for you for sleep apnea, how would you approach that patient?
Good question. So again, it's that notorious answer of, well, it depends.
Yeah.
In general, if a patient's referred, I get what the chief complaint is on the referral. So I know going in initially, we're going to be addressing what they were sent here for, whether it's insomnia or sleep apnea or what have you. But it's finding out what that issue is, addressing that, but then also diving into their sleep in general. Sleep is kind of, it's low hanging fruit for us in healthcare, that it's as simple as, how's your sleep? And you can learn a lot about a person just by asking that simple question. We used to have a 4-page long sleep questionnaire that all of our new sleep patients would fill out, and they would hate it, and they would have to sit in the waiting room for 30 minutes filling it out. It was just a combination of a bunch of different screening questionnaires.
Yeah.
And in general, I'm an auditory learner anyway, so I like to hear from the patient what their complaint is in their own words rather than shorthand.
Agreed.
And that really helps me get to know them and what their true issues are, just by asking them a bunch of questions and letting them walk me through it.
Yeah. I mean, simplest way to go about that, right? Listening to the patient first and going from there.
Right.
Yep. How quick do you go about getting a sleep study or having them do that? I guess, is that purely, I suppose, dependent on, okay, well, they have sleep apnea, or do you do sleep studies for insomnia and things like that as well?
So sleep studies really only serve a role for sleep apnea,
Mm-hmm.
limited, benefit for the insomnia and restless leg type patients, but
Mm-hmm.
predominantly you're only going to get a sleep study if you suspect there's some sort of sleep breathing disorder. We utilize home sleep testing
Oh, okay.
more than in-lab testing. It is less sensitive, but it is much more natural type sleep.
Mm-hmm.
They sleep in their own bed. There's not 1,000 wires. There's not somebody staring at them all night. Nobody sleeps well in a sleep lab. So
Right.
the home testing we go through use the watch pat device, which is literally a watch and a finger probe, and then a sensor on the chest,
Oh,
very small and non-intrusive.
Hmm.
Um, and they used to be read by Dr. Todd Huntley within our practice, which is great because if I needed clarification or wanted him to drill into data, I could just walk over and ask
Yeah.
him. But the company that provides those tests, Zoll Itamar, has done a great job contracting, and we actually get results back next day
oh
most
wow.
of the time.
Okay.
So it's been a good working relationship, and people really appreciate the home sleep tests, especially if they've done the in-lab test before.
Oh, yeah. I believe
Most of them
that.
come in saying, "I'm not going to do that again."
Yeah.
Yeah.
I totally understand.
Yeah. Do you get pushback from like insurance on home versus in lab? Like, I don't know, is there
So the big
cost
pushback is
difference?
if you order an in-lab study.
Oh,
Um,
yeah.
so those cost a lot of money.
Uh-huh.
And like the home sleep testing, I'm not going to quote anybody a price because obviously insurance determines
Right.
things, but you're talking about a couple $100 versus a couple $1,000
Wow.
uh,
That's
for the home versus in lab. So
Okay.
significant. Yeah.
when it comes to the ordering a home sleep test, as long as you have documented in your note suspicion
Uh-huh.
for sleep apnea that's reasonable, then I
You don't have
rarely
any
ever see a
issues.
denial for that.
That's
That's good.
awesome. That's good. Yeah. Insurance is a loose cannon sometimes.
It doesn't make sense half the time we deal with
Yeah.
it.
No, that's surprising though, because I mean, in lab studies have been the gold standard for forever before that. So you'd think
Yeah,
by now they'd be more cost friendly, but
Yeah.
yeah,
that's
absolutely.
that's
And
interesting.
it's hard with in-lab studies. I wish it would be easy and
Yeah.
Mhm.
comfortable and tolerable for people because it is the gold standard and very sensitive and specific, and it can dig into the limb movement and that type of stuff. But it's there's the sleep labs are consolidating, and there used to be independent sleep labs everywhere.
Yeah.
The last remaining holdout independent sleep lab that I'm aware of in the central Indiana area just closed and consolidated with a hospital sleep lab. So there's only a handful of them around, and it's hard to schedule because there's a lot of people with sleep apnea.
Yeah.
Yes, that and a lot of people who just live with sleep apnea and don't ever get tested, or they very well know that they have sleep apnea and they don't
wanna
want to
do
do
anything
anything
about
about it.
Exactly,
Yeah.
exactly.
Which can lead to a
Yeah,
whole
there's
host of
estimates.
issues.
Yeah, there's estimates that there's you know about 80% of the people with sleep apnea in this country are undiagnosed. Um, and we're talking about there's already 20 something million people diagnosed in this country. So
Oh my gosh.
there's a lot of
80%.
potential sleep apneics running around town that just think that feeling tired is the way you're supposed to be.
Yeah.
Oh my gosh.
So what are some long-term side effects of not treating your sleep apnea?
Very good question. So the most well documented, well known risks are the cardiovascular risks. So
Mhm.
dramatically increased risk for heart attack or coronary artery disease. We know now, and it's been a lot of evidence to come out relatively recently, that sleep apnea is a trigger for AFib. So we get a
Oh.
lot of referrals from cardiology for the new AFib diagnosis. Um, but there's also risk for dementia, increased stroke risk, increased risk for diabetes, type 2 diabetes, certain types of blood cancers, car crashes, ortho injuries, and recurrent illnesses. So pretty much anything that can go
Y-
wrong with you can with
Yeah.
untreated apnea.
Yeah. Let's work even more backwards from there. Since we're talking to our women population, what would be some of like the signs and symptoms that they might be experiencing if they suspect they have sleep apnea?
Absolutely. So, with a lot of things in medicine, men and women, can sometimes have different symptoms or presentations. Snoring and excessive daytime sleepiness are the two most common symptoms that everybody will report. But sometimes snoring is not immediately recognized because it's just maybe loud breathing, or like a purr, or if their bed partner is a heavy sleeper, then they may not hear the snoring, so they just don't know. Or if you don't have a bed partner and nobody's told you that you snore. But the daytime sleepiness is a huge, indicator that somebody needs to look into something, whether it's medical or, sleep issues. But mood disturbances is a huge partner with untreated sleep disorders as well. Sleep is necessary to regulate mood. The hormones are the same and connected. So, treatment refractory depression is commonly seen in sleep apneics or insomniacs, as people with poor quality sleep. Hypertension is a big one. So hypertension that, again, is refractory to treatment. People may be on 2-3 meds and still having spikes in blood pressure. I recently actually worked up a local woman that's why she was sent here. She's on blood pressure medicine and she's still having some dramatic spikes and wanted to try to find a reason for it.
Yeah.
And her primary nurse practitioner recognized that and sent her over to see us.
Oh, wow.
So
that's great.
It could be something as simple as that, or waking up with panic attacks or anxiety in the middle of the night. And then a common one is waking up with morning headaches, or shortly thereafter waking up having a headache or migraine due to the low oxygen levels at night.
I'm trying to think about myself.
I know. I'm thinking like, oh no,
I might be coming to see you soon.
Come on over. I'll take care of you.
Well, okay, ladies, if you have any of those symptoms, pay attention to them and bring them up with your healthcare provider. But that is so interesting to think about. I mean, I knew some of them, but like not all of them did I think about. Even like the refractory hypertension, I just kind of thinking about that in detail. Like I know a lot of people that struggle with that in my life. So
absolutely.
Oh, wow.
Absolutely. Do you notice a worsening of symptoms or more women, I suppose, coming in after menopause or like during the perimenopause to menopause?
Absolutely.
phase?
So when it comes to sleep apnea specifically, women are at a significantly lower risk for sleep apnea than men until menopause. And then the risk is the same. So the same likelihood as men.
Wow.
Which there's some airway protective mechanism of estrogen that we just don't understand yet.
Okay.
But we do definitely see a dramatic rise in sleep apnea in women at or after menopause. And then sleep apnea as a disease worsens with age in general.
Gotcha. Is it because like you lose tone? Like why?
Yeah. Lose muscle tone, lose
Okay.
respiratory drive, lose strength and conditioning within the ribs and the diaphragm.
I see.
The chemo oxygen carbon dioxide receptors in the brain alter over time, become less receptive and sensitive. So it's a combination of many factors.
Oh, wow.
Okay. And then just throw in the lack of estrogen and
Yeah.
You get that
You get the
estrogen
world.
again, striking again.
Oh, I know.
Speaking on that level, we see a lot of women, perimenopausal, menopausal. We are unfortunately inducing them to have a lower level of estrogen. They struggle a lot with sleep, particularly falling asleep, staying asleep, more that insomnia type of picture. Is that something you also see a lot too? Is outside of sleep apnea after menopause, do you see a lot of insomnia and those women struggle with insomnia as well?
Yeah, absolutely. So, and I actually just made sure that I was going to give you up-to-date numbers and information here. So 40 to 60% of perimenopausal women report some sort of sleep disturbance. Doesn't matter what it is, just some sort of sleep disturbance. And there's been several kind of large studies, retrospective, prospective studies to try to find out what it is about menopause or perimenopause that triggers it. And the studies are very split. So in real life, yes, I see an increase in women coming in for insomnia and or sleep apnea and or restless leg after or at or after menopause. But the studies, they're trying to find a link, the vasomotor symptoms with the hot flashes. But but there's women that have hot flashes and don't have insomnia, and
Yeah.
women that have insomnia and don't have hot flashes. So maybe there's a link. But with perimenopause, menopause, it certainly is multifactorial. So the timing of in your life, if you had kids a little bit early on, then perhaps your kids are moving on and moving out of the house. So then you get the empty nest, midlife crisis that we all go through, uncertainty about the future and retirement and stock market, all that stuff.
The fun stuff.
Just everything piles up right around that same time. And it's just the perimenopause start is just the icing on the cake for, letting the good times roll. And sleep unfortunately suffers when we're stressed or anxious or worried, or just, you're just kind of on edge.
Yeah.
And
Yeah, absolutely.
they did state in this one, it was actually published last year, a meta-analysis from the American Academy of Sleep Medicine. The biggest risk factor for insomnia in perimenopause or menopause women is having a sleep disorder going into it already, or already having a history of depression prior to perimenopause. Those two things certainly will worsen once the perimenopause period starts.
Yeah.
Yeah. I mean, that makes total sense.
It does. I was going to ask about mood, and if you see a high relation also to mood and insomnia too. So, wow, that is crazy. I believe it. I mean, we see it. We see it happen.
I'm sure you do. Yeah.
Yeah.
Absolutely.
Absolutely.
And I mean, I know I've talked to you a little bit about this. We have a lot of our women struggle, so they're trying everything under the sun. We're doing, they're doing magnesium, they're doing melatonin, they're doing Benadryl, they're doing Tylenol PM, like all the things. I know particularly one thing that you practice is, I had to write it down to remember, BBT-I, which stands for Brief Behavioral Treatment for Insomnia. Is that correct?
Correct. Yep.
Okay.
Correct.
Tell us a little bit about that.
Sure. So insomnia is a complicated disorder. There's several different, technically, there's several different subclasses. No longer recommended to try to subclass them because most providers can't really differentiate between all of them. But the majority of it is psychophysiologic, which is a combination of kind of the mental state, the subconscious, unconscious change in thoughts with sleep and mood and all of that stuff, combined with then the subsequent changes in behaviors around the bed, the way you view the bed, the way you prepare for bedtime, those kind of things. So the gold standard treatment recommended by American Academy of Sleep Medicine and really kind of any organization that treats sleep disorders are behavioral management programs. Cognitive behavioral therapy is the first for insomnia. But the problem with it is there is a very small number of certified BBT-I behavioral sleep medicine specialists. Behavioral Sleep Medicine Academy, you can do a search for providers on their website, and there's just over 400 in the country. When we're talking about at least 25 million people with insomnia. So as I like to say in office, the math ain't math in there. And it's very hard.
It is not.
No, it is not.
Yeah. So researchers developed this brief behavioral treatment. It was originally developed for primary care to make it easier to implement by taking the cognitive portion out of it, the talk therapy portion.
Okay.
And focusing on solely on harnessing our innate sleep drive, the sleep pressure, as well as the circadian rhythm, and kind of just taking over control of our sleep habits. The brain stem and the primitive portion of our brain, the lizard brain portion, is very powerful, and it's very reactionary, and it doesn't listen to logic or reason, and it kind of runs us and does whatever it wants. So we have to take control. We, as in the prefrontal cortex, we have to take control of it and force it to do what it's supposed to be doing all along. And it is a very relatively quick process. CBTI can take 6, 12, 18 months sometimes. People have lives. People get frustrated. People move on. It's hard to get in to see them. Follow-ups can be difficult, especially if you need to touch base sooner than what was scheduled 6 months ago, that kind of thing. So BBTI is a The first visit for it is an hour long, and it's primarily directed at education because, and I'm this way, and I'm sure the majority of people are, that if you know why you're doing something, you're much more likely to actually do it.
Agreed.
Pay attention and follow along.
Yeah.
So educating people about sleep, why we do it, what we're doing to affect it, the things we don't know that we're doing necessarily. We talk about insomnia, what it is, where it started, what's keeping it going. And then we develop their sleep prescription, which is their quote unquote rules for better sleep, incorporating sleep hygiene, et cetera. And then sleep restriction. Sleep restriction and stimulus control are the two biggest things that you can do to immediately affect sleep. And it's not necessarily trying to make them sleep shorter. I'm just trying to eliminate that period of time that they're supposed to be asleep, that they're just laying in bed awake.
Okay.
So I have to caveat that every time with people, because they're like, I'm already terrible at sleeping, and now you're going to tell me I get to sleep less.
Yeah.
Nope, that's not it. I'm just trying to you're going to teach your brain that when it's time to sleep, you're going to sleep. It's not laying in bed throwing a tantrum.
Yeah.
And then
scrolling.
we set expectations. They have a sleep journal they fill out, and I see them back every 2 weeks, typically for 2 or 3 more appointments.
Wow.
And if they're doing well and progressing appropriately, then I stretch them out to 3 months, 1 year, and then annually at that point. But if they need more help, or if we need to tweak it and kind of go off label here, so to speak, we can personalize it any which way that works for the patients, and I can see them back as frequently or infrequently as they feel is beneficial to them.
Wow. So how many people roughly are able to progress pretty quickly versus like having to continue to tailor it more and more, or personalize it, I should say?
So statistically speaking, the analysis that got this, kind of approved by the American Academy of Sleep Medicine found that 85% of people had remission of their insomnia following that kind of initial course.
That's really good.
That's good.
It is really
85%?
good, really good, which is much higher than medications are for sure.
Yeah.
Surprisingly. But I estimate I'm around 90, low 90s% success rate.
Okay.
I've never published it. I've never actually done a formal analysis. Maybe patients just stopped coming in to see me because I made them upset. I don't know. But I haven't done a kind of a analysis, or even just kind of a anecdotal analysis of how many people needed kind of additional help versus the ones that just did the first couple of visits and were great.
Yeah.
It's pretty high success rate with just those initial visits. They can get better.
And is this like weaning them also off medication in the same process, or are they staying on the medications? Like, how do you deal with that?
Again, behavioral treatment's the gold standard.
Yeah.
But medicines are the most common. Medications, I'll talk to you about that in a little bit.
Yeah.
Not preferred because it's not natural sleep. Sedated sleep is not healthy sleep. There are safer medications, but ideally, I want to get them to be able to sleep somewhat consistently and predictably, and then taper them down off of their medication. It works best if they can just quit altogether. Cold turkey it, just suffer it out for a little bit when you're first starting this, because building up your natural sleepiness is how this works. So you're gonna be miserable the first week, regardless if you're on sleep meds or not. So long-term gain, short-term pain kind of thing. I used to see people back after 1 week, and they all universally hated me. And after 2 weeks, they loved me. So now it's every 2 weeks.
Yeah, now you don't have to suffer through.
Good plan.
But I do, if they're on medications like Ambien or Lunesta, I do transition them typically to something else that's not as sedating for the GABA portion of the brain, and easier to wean off of. Like I use temazepam frequently for that. Because anxiety is very frequently the underlying trigger or source of the start of it.
Okay.
Because I figured most people, by the time they come and see you, they've probably tried the whole gamut, or they're on something when they see you.
Absolutely. That
Oh,
is
jeez.
most common. Most commonly, by the time I see them, they are certainly have tried at least 2 or 3 meds. Um, it is, unfortunate. Some they see me, they've been on Ambien since it was FDA approved, whatever, 20 plus years ago, which is not ideal.
Mhm.
Yeah.
So we do the best we can. Some patients have to stay on some sort of sleep medication. The problem is if they're on sleep medicine and still not sleeping well.
Yeah.
So if I can get them sleeping well and on a sleep medication still, that's still a majority win. They're
Yeah.
getting more sleep than they were. I will try to at least convince them to try to come off of it.
Yeah.
But again,
Uh,
patient's choice, and I'll
right.
respect that choice and help them out as best I can.
Yeah.
Yeah. So you mentioned you do a decent amount well, you'll do like anxiety medicine. Do you ever recommend hormone, like doing estrogen, progesterone, things like that?
So I'll be honest, that has not been on the top of my list of concerns
Okay.
or
Good.
focus, I
Yeah.
should say. We definitely know that if your hormones are imbalanced, then your metabolism of medicines and utilization of them is not going to be as efficient anyway. So I think all of us could stand to improve our awareness and understanding of that balance
Yeah.
and relationship. But I honestly, I trust that primary care has been addressing that or at least looked into it. Um, if I do have concerns that there's a significant imbalance or something, I will order labs, but I don't ever prescribe hormone treatment.
Yeah. I would
Okay.
never expect you to have to do
No.
that.
Yeah. Just curious.
Yeah.
Yeah.
So if there was any medication that you would recommend for sleep, what would that be?
So as of right now, kind of with our understanding of the brain and neurology and sleep architecture, which is the brainwave fluctuations through sleep, there's the newest class of sleep medicine. They're called DORAs, or the dual orexin receptor antagonists. There's 3 of them: Quvavik, Dayvigo, and Belsomra.
Oh,
They have been shown, particularly Quvavik, which is the newest one, to not have any impact on the sleep architecture. So it allows your brain to get in all stages of sleep, which is necessary for good cognition and brain health. Um, it is a great medicine. It does have some side effects. They do have some side effects, I should say. They can mimic narcolepsy side effects, sleep paralysis, hypnagogic hallucinations, which is dreaming before you're actually falling asleep. But the problem is that they are nowhere near as potent or fast acting as Ambien and like medications are. So if they are on that already or have tried that, they've kind of desensitized themselves to what the effects of these DORAs could be.
okay.
Okay.
But I do, like I said, lean on temazepam or triazolam a lot because they're technically benzos, which
Yeah.
does raise a lot of red flags for people, understandably so. But these ones are only labeled for insomnia. They aren't fast acting. They've got a longer half life, so there's very little to no concern about tolerance or dependency issues. And again, like I said, especially if anxiety is the underlying issue, it is very effective for that purpose.
Okay. Kind of same thing with those meds and insurance. Since they're newer, do you have to like trial and fail a few?
Yes.
Yeah.
Yeah.
I figured.
Yeah.
And they can be expensive,
Absolutely.
I imagine, right now.
Yeah.
Yeah.
Yes. It is a pain.
Yeah.
And I hope that we evolve from this situation we've gotten ourselves
Absolutely.
into with all of that. But also, as more and more information comes out, these newer medications become more first line. But also then when they transition to generic, that makes it much easier
Yeah.
for insurance to approve it.
Yeah. It's the name of the game, right? You just going through this,
Gotta grin and bear
unfortunately,
it for
until
now.
till something changes.
We got to play the game. Yeah.
Unfortunately.
So supplements are also like a huge thing, and in the era that we live in right now too, I feel like everybody, especially women, they really want to try supplements before they try any medications. Are there any particular supplements that you personally have seen work well or that you recommend that? people use?
That's fantastic. And honestly, the less pharmacologic, the better in general.
Yeah.
So again, ideally, sleeping without any assistance would be preferred. Magnesium is the big one that is kind of growing in its marketing and advertisement and such. It is very safe, and there is a growing body of evidence that it is effective for sleep.
Notorious user over here.
Whatever works, right?
Yeah.
So there aren't a lot of studies about its effectiveness, and some of them
Okay.
are kind of mixed, but
Mhm.
the majority of studies show that it is beneficial. But
Okay.
honestly, we have no idea why it's working.
Interesting.
Could be something to do with relaxation and muscle, control, relaxation. Nerve synapses firing. It does perhaps have some effect on dopamine, serotonin, GABA, NMDA stuff in the brain.
Mhm.
But it's safe, incredibly safe to take. The caution is one type makes you go to the bathroom and the other one helps you sleep. So
Yes.
the glycinate is the better one for the sleep issues. So
I was going to
Thank you for
clarify that. I was going to
clarifying.
make sure that we said that. I did not want people going out there
Fair.
buying mag citrate. Do not. The
that will
glycinate.
make your sleep much worse.
Much, much worse.
Yeah.
So like dosing for the magnesium glycinate, there's a wide range of availability
Right.
out there. What is like the max dose?
There is, and I don't even attempt, because there's so many
Okay.
different formulations, so
Yeah.
many different qualities. I basically say, pick one that's third-party tested,
Mm-hmm.
and take what's labeled. Don't take more, don't take less. Just take what's labeled. Third-party tested, of course, is this a very good standard to have in supplements,
Mm-hmm.
but that's also not a guarantee of anything. And here in a second, I'll tell you about melatonin and how third party doesn't necessarily help, but it is much safer than the non-third party tested.
Okay.
Okay.
That makes
and,
sense.
and always do research. There's tons of true scientific data, not just forums, etc.,
Mm-hmm.
that can help you differentiate dosing and things like that. But as far as official recommendations, there isn't
Okay.
an
Okay.
official labeling for sleep as far as magnesium goes.
Okay.
Okay.
Yeah. Good to know.
And then tell us about melatonin.
Yeah. So melatonin, this is one that I could spend probably an hour talking about. It's not great. The
Really?
studies for the majority of the studies show that it really is placebo.
Okay.
Which honestly, if placebo works, it's medicine, but it doesn't necessarily work. And we don't even know if it does what we think it's doing. So we don't know if oral melatonin crosses the blood-brain barrier. So
okay.
if it doesn't do that, it's not going to affect your brain.
Exactly.
Right.
Additionally, there's been a couple of studies over the years. The most recent one was in 2023 that they tested 25 over-the-counter brands in the United States. 22 of them, the labels were inaccurate for the amount of melatonin that was actually in the dosing.
Oh, wow.
Wow.
And they found that each capsule or tablet could contain negative 74 to positive 347% of the melatonin as to what's labeled on the bottle.
What?
That's a gigantic
That's
range.
huge. Oh my gosh. Cue
And
every woman listening dropping their melatonin bottles right now.
And they can contain up to 50% serotonin, which is the opposite hormone. It is our wakefulness hormone. Serotonin is converted into melatonin in the evening when the light starts to dim, which is why people think you should take it and it'll help you sleep.
Yeah.
But it's also super, super therapeutic. So our natural production is about 0.1 milligrams at most.
Mm-hmm.
And if you're taking 10 milligrams of it, that's way more than what our body's producing.
Yeah.
So if it is getting into the blood-brain barrier, it is overwhelming our system. And what we know about hormones is that if you take an exogenous hormone, your body will say, I don't need to make this anymore, so I'm going to chill out. And then you have trouble getting off of it. Again, is that what's happening with melatonin? Nobody really knows.
Yeah.
Oh, that's wild.
I'm just thinking of like all the parents that have children on melatonin.
Yeah, so many kids are on melatonin.
Yeah.
Which you're kind of, you know, I'd be a hypocrite if I said I didn't
Yeah.
give my kids melatonin from
Yeah.
time to time, but definitely setting them up from an early age to need assistance with
Yeah.
sleep.
Yeah.
Additionally, there's been a couple of studies looking at overdosing in kids. So between 2019 and 2022, there was 11,000 emergency room visits for melatonin overdose in the United States.
Oof.
There was a couple of deaths as well of kids overdosing on melatonin.
What? Oh, that's scary.
So because it tastes like a gummy bear,
Yeah.
Yeah.
they really do taste good. I'm not gonna lie, but it looks like a gummy bear, tastes like a gummy bear, and they just get the bottle open and it's not child protected, and they'll just take the whole bottle.
Oh my gosh.
So exercise caution, of course.
Yeah.
Yeah.
And the other thing about the quality is in the United States, there's no such thing as pharmaceutical grade melatonin.
Mm-hmm.
It's 100% supplement grade.
Mm-hmm.
And as supplement grade, there's no FDA regulation or
Mhm.
study into it or purity regulation.
Yeah.
And OTC melatonin has been banned in the UK, European Union, Australia, Japan, and most recently in Canada. So we are essentially the
only
last
country.
remaining first
Oh my
world country to still allow over-the-counter melatonin sale.
Oh my gosh.
That is terrifying.
No more melatonin. Everybody stop that melatonin.
Yeah.
I'm not
Okay. Yeah.
Wow,
Now,
that's so much
I'll
information.
caveat there's sleep medicines in general serve a role.
Yeah.
I'm not bashing all sleep medicine. They definitely serve a purpose for some people.
Yeah.
Melatonin actually, first, let me back up. So the American Academy of Sleep Medicine published a pharmaceutical guide for management of insomnia, rating the improvement and quantity for sleep. And they had a couple of medications that they recommended against using because the risks outweigh the benefits.
Okay.
Benadryl, melatonin, trazodone, L-tryptophan, and valerian. So melatonin is one that they recommend against using in general.
Mm-hmm.
They do have guidelines for jet lag disorder, and melatonin does serve a role there.
Oh,
But
interesting.
only for up to 3 days.
Oh. Okay. That would have been good to know after my recent Greece trip. Dang. Although with all the information you just told me, I still probably wouldn't have taken it.
Probably
Just go
better.
Dang, like 3 of those that you just named, Benadryl, melatonin, and trazodone. Those are like 3 top hitters when it comes to what people take.
Yeah.
And trazodone is very common, and
I hear it a lot.
it is effective for a lot of people, but the problem is it's an SSRI.
Yeah.
And so it increases serotonin levels, which again is the opposite hormone of melatonin. Surprisingly, it is a very sedating SSRI, but especially if they're already on an SSRI, now you run the risk of serotonin syndrome.
Yeah.
And then if they're adding melatonin, that's 50% serotonin, increase the risk. So in general, and when you're dealing with SSRIs are known to suppress REM sleep. So we need REM. Without REM, you are a huge risk for dementia. So
can you explain what REM sleep is for our listeners too, really quick?
What was that? I'm sorry.
Can you explain what REM sleep would be for our listeners?
Oh, yes. So rapid eye movement sleep, that's what we believe is the memory consolidation phase. Okay. So I described sleep in the 2 phases, non-REM and REM. And non-REM is like the download of the information from the day. It all of your experiences from your RAM, your short-term memory getting pushed over to the hard drive. And then the REM sleep is where your brain is taking all of those memories from the day and then trying to mix and match it with existing memories and pathways that it already has, try to store them efficiently, see what works and what doesn't. And part of the function of sleep is to facilitate that is that the prefrontal cortex is where our logic center exists, the right and wrong center. So it slows to a crawl during sleep. So you can make crazy, wild mistakes in your dreams to see if memories work, which is why you'll jump off a cliff or put your hand on a hot stove during a dream, but not during awake. So it's trying to find a way to consolidate those memories to save space, essentially.
That's good. That's a really good explanation. I
Wow.
love that. But anyways, I think I stopped you in your previous statement. So if you remember what you were going to say.
No, I don't.
That's okay.
Mind blow.
That's okay.
Let's go back to Benadryl. So downsides of Benadryl, a lot of sleep aids, like over the counter sleep aids are essentially Benadryl. So yeah, let's talk about that.
Yeah. So, and it wasn't labeled, FDA labeled for insomnia or sleep disorders until relatively recently. But it was used off label for decades.
Yeah.
It's a first generation antihistamine, and it's non-selective in the histamine regulation. So you have three types of histamine. So histamine 1 is your general histamine in your body. That's the allergy symptoms, the sneezing, itching stuff, eczema. Histamine 2 is stomach acid, and then histamine 3 is in your brain. And an increase in histamine in the brain, central histamine, makes you feel more awake and alert. So an antihistamine that affects the brain, H3 histamine, will make you feel sedated and sleepy. So that's how its mechanism works. Now, the problem with it is that there's a fairly decent chunk of the population that get the inverse reaction, the paradoxical reaction to Benadryl. And they get the cholinergic symptoms, flushing of the skin, racing heart, really revved up. They can't sleep, aggression or anxiety, those kind of things. So if you're trying to sleep and you take it, that's not a good idea. But also, antihistamines, first generations, they lock you into sleep, which is middle stage sleep, which about half of our night should be, at least half of our night should be in that middle stage sleep. But this kind of keeps you in that block and prevents you from going up and down, which is what you need to do with your brain waves.
Gotcha.
So again, it impairs memory download and storage, and increasing risk for dementia.
Okay. And that's proven too, isn't it? I feel like I've seen a lot of articles recently about the long-term use of Benadryl
For
leading to
dementia.
dementia.
It's been known for a long time, actually. It's just,
Yeah.
and still it got approved for sleep disorders.
That's incredible.
I don't understand.
Huh.
So weird.
Yeah.
Okay.
Yeah, so many people use that. What about CBD? That's a hot one too.
Yeah, so that's a growing one. And understandably so, there not a long history of research with it. So the CBD that's allowed to be sold is derived from the hemp plant, not the marijuana version, the THC version. But it has been shown in many studies that are admittedly small, but many studies that it can help with anxiety, can help with muscle relaxation, it can help regulate pain, and then a growing body of evidence that it can help facilitate sleep. Now, it is unknown if it's because it's relaxing you and helping with muscles and pain, et cetera. Is that what's facilitating sleep, or is it some other central mechanism that's making you sleepy?
Yeah.
But it's working for a lot of people. It doesn't work for a lot of people. And there are, just as with anything, there's potential risks, but much safer than a lot of the prescribed alternatives, to be honest with you.
Yeah.
Absolutely.
GI symptoms are typically the number one, side effects from it. So
Okay.
obviously, again, maybe a problem if you're trying to sleep and having GI side effects, but otherwise it's a reasonable attempt to try a supplement before medications, for sure.
Yeah. And I think that's fair. And I'd like to think that people are starting, at least maybe younger people and younger generations are starting to feel that way and think that way. I mean, I've seen even a lot of my ladies that they just don't want to take medications. They don't even want to take their
like supplements,
breast cancer medication. So, it's like, well,
I am seeing a lot more and more patients that are questioning things, which is good. Healthy skepticism is good.
It is.
That is very post-COVID.
Kind of being very reluctant to try medications, which again is a very reasonable desire, to not have to carry the whole pharmacy with you. But again, medications serve a purpose.
Agreed.
Agree.
So
there you go.
sorry.
You can go.
I was just say, so if you're not using medications or you want to avoid medications, what are some things that you typically recommend just overall for good sleep hygiene?
So, sleep hygiene is it's a commonly said but misunderstood or poorly
Uh-huh.
understood idea. And a lot of people say, I need to work on my sleep hygiene, but then you ask them what is wrong with their sleep hygiene, and they can't really give you examples. The phone, everybody knows the phone. But
Mm-hmm.
so sleep hygiene is the generic term, and you need to work on it. And the biggest things that you can do to help improve your sleep, just trying to tweak things yourself at home before talking to a professional, would be
Mm-hmm.
a consistent wake up time. So when we're young, our moms told us it's bedtime, and you said, I'm not sleepy. And they said, well, go and lay in bed and close your eyes and rest. That type of mentality as an adult actually facilitates the development of chronic insomnia.
Oh.
Our body, our brain circadian rhythm, which is our sleep wake cycle, is actually derived from back planning from our anticipated wake up time. So if
Yeah.
our brain doesn't know what time we're going to wake up, it kind of goes haywire and does whatever it wants. So having that same time, wake up time every day of the week, no matter
Mm-hmm.
what, very important. And if you didn't fall asleep, until 3 hours before, all that's going to do is help you fall asleep easier the next night.
Mm-hmm.
Um, Having a consistent bedtime routine is also good. But what a lot of people will do is they will do something relaxing, meditation, breathing exercises,
Yeah.
and then get up and go and do all of their nighttime stuff to get ready for bed, which then just wakes them back up.
Yeah.
Yeah.
So I would certainly recommend allotting a 30-minute cool down window after you get ready for bed.
Okay.
Your cool down activities should not be done in bed. You need to teach your brain to associate your bed with good sleep and nothing else. Well,
Mm-hmm.
sleep and sex. That's it.
There you
Um,
go.
Thank you for
but watching
that.
watching TV in bed, reading in bed, staring at the ceiling, tossing and turning in bed, all those again just reinforce to that childlike primitive portion of our brain that that's what it's supposed to do in those
Uh-huh.
scenarios.
Mm-hmm.
So we need to again retrain our brain to view it in the way it's supposed to be viewed, which is for good sleep. Um, should not eat too late. So generally 3 to 4 hours before bed
Okay.
is when your last oral intake should be, unless you're like starving and your stomach is growling. You
Mm-hmm.
can't sleep well if you're really hungry, but if you're actively metabolizing food or breaking down food, your body isn't able to shut down properly. So yeah, you're asleep, but you're not really good asleep.
Mm-hmm.
Um, TV, screens, phones, computers, twofold negative effect on sleep. The biggest kind of most well documented phenomena is the light exposure.
Yeah.
So light is the stimulator. It's the number one stimulator for our wake cycle. And then dim light or lack of light is the number one stimulator for the sleep portion of our circadian rhythm. Specifically, the blue light, which is the highest energy wavelength of visible light,
Mm.
that is the most stimulating. And LED screens put out a boatload of blue light. So trying to minimize or eliminate screens for an hour or two before bed is certainly recommended. The more time, the better. Um, you can more safely utilize screens by
Mm-hmm.
shifting it to the red spectrum, the warm spectrum of colors, dimming the brightness down a whole lot,
Mm-hmm.
or a blue light film, the blue light blocking film on glasses or on your screen protector. But those can only do so much because it's still light, and all
Right.
light stimulate wake up. But the other one that's kind of less thought of by a lot of people is the mental health aspect of news and social media.
Mm-hmm.
Oh, yeah.
Um, so during my BBT-I, for 4 to 6 hours before bedtime, there I say no news, no social media, no email,
Good.
because nothing good ever comes from those.
Yeah.
Mm-hmm.
It's all bad stuff.
Agreed.
Agree. Yeah.
Only going to stress you out more. So just
Right.
stay away from it. You're going to be better for it.
Yeah.
And utilize that time to, to maybe learn a hobby, something that you've been putting off because you don't have the time, provided it's not something that requires a lot of cardiovascular work and being
Mm-hmm.
outside, et cetera, operating heavy machinery. You don't want to do that when you're sleepy. But, surprisingly, a lot of people take up knitting or crochet or something like that. It's kind of
Nice.
very cathartic
Yeah.
and calming
Sounds
and
nice. It does.
easy to pick up.
Yeah.
But reading is great. So
Yeah.
reading is calming for a lot of people,
Mm-hmm.
unless you're the page turner type person that can't put books down.
It's me.
Then avoid book. You got to know your triggers, right?
Yeah.
So during my interview for sleep disorders period, but also specifically with the BBT-I, it's
Mhm.
identifying those triggers and then the behaviors to replace them with that
Okay.
helps lead to success. TV on to fall asleep, radio to fall asleep, not good. Having white noise is fine. And a lot of people need that.
Yeah.
That's okay.
Do you hear that, Ross? My husband's back here. I sleep with a fan and he yells at me
Yeah.
all the time.
It's
The
prescription.
white
now,
noise
you
is
have to do
good.
it. Yeah.
Yes.
So the TV, the flickering light, you can see light through your eyelids. That's not good.
Mhm.
But anytime a sound, tone, or tempo fluctuates, it re-triggers our brain to alert to it and pay attention to it. So you may be listening to a song that's calming and relaxing, but then the next one, the tempo changes, and now it stimulates your brain to pay attention and wake up a little bit.
Yeah.
Same thing. We've all watched TV and it's super quiet. You have to turn up really loud, and then a commercial comes on and you're deaf. All of a
Yeah.
sudden. So those kind of things will most certainly interrupt your
Oh,
sleep.
wow.
Yeah.
So
Okay.
many
then-
things. Oh my
Makes total
gosh.
sense.
Very. I was also going to just kind of touching back on the perimenopause, menopause, sleep disorder onset type
Yeah.
thing.
Yeah.
Multifactorial with the timing of life. So you add in the hot flashes. Regulating your sleep patterns is not going to eliminate hot flashes.
Yeah.
Mhm.
But then if you add in maybe retirement to that, for anybody, not just women, but anybody, retirement is a huge trigger for insomnia. And that's because your schedule went away.
Yeah.
Your routine went away. The
That makes
predictability
sense.
of life went
For
away,
sure. Yeah.
which can make you depressed or sad. But also, I'm personally going to be happy when that day comes. But our body needs routine. Our brain needs routine. Daytime routine is far more important than nighttime routine.
Yeah.
So back planning our sleep and wake cycle, our brain says, what's coming tomorrow? And then how much cortisol or stress hormone do I need to release to prepare me for the day?
Mhm.
And again, if it has no idea what's coming, it's going to plan for worst case scenario. It's very reactive. That brainstem has not evolved since, saber-toothed tigers were trying to chase us down.
Mhm.
And it doesn't understand that having to, go grocery shopping is different than foraging for food.
Yeah.
So it will plan worst
Just-
case scenario and dump a bunch of cortisol into your bloodstream and ramp up anxiety and all of those things that come with it.
Yeah.
So you need to
Okay.
make sure you have kind of not necessarily strict planned activities, but you need to have something predictable, routine going on during your day.
Yeah. That makes sense.
I totally see that in practice. I can't tell you how many women I tell once they retire, if they're planning for retirement or if they are in retirement, and especially the more depressed, it does seem like the women who do, and men of course, who do continue to have a routine or work in some capacity or have that day-to-day purpose, they look and feel the best. I have 70-year-olds who could easily run circles around some of our 50-year-olds.
Yeah.
And they
Absolutely
continue to work part-time at something they enjoy, but it's
Or
predictable.
They're getting up and they're, have a schedule for the day, meeting with their friends,
Exactly.
going out to lunch or what have
Yeah.
you. Just
Huge difference.
stimulus of staying
Exactly.
alive,
Yeah.
literally just doing life things.
And that's what I even tell them, it doesn't have to be clock in, clock out type of stuff.
Yeah.
It could be,
Yeah.
I know when I wake up, I stretch, I brush my teeth, I grab a cup of coffee and I sit on the porch and yell at the neighborhood kids or something.
Yeah.
Just something planned for the
Something.
next day.
For sure. Oh, well, this truly has been wonderful. Obviously, we could talk for such a long time. I mean, we could dive even deeper into the sleep cycle, circadian rhythm stuff, getting more into the REM sleep, definitely. But we have loved talking to you.
Yeah, a wealth of knowledge.
Obviously. So much to learn. Is there anything that you want to end on that's a drive home point that you want to tell the audience, or fun fact, or whatever you want to say?
So I would say that it's important to recognize that we as a society, we undervalue the importance of sleep. And sleep is the most important thing aside from food and water that keeps us alive.
Mm-hmm.
If you don't sleep, you die.
Mm-hmm.
And if you don't sleep enough, you die faster. But it's a less healthy lifestyle. So we really need to collectively change our mindset from the Industrial Revolution era of if you don't work from sun up to sundown, you're lazy kind of mentality to you work your best when you sleep properly. Your mood is better controlled. People like you better when you're sleeping more frequently and soundly.
Yeah.
You can take care of your family and friends and responsibilities better if you are well rested and sleep better. And it improves literally every measure of health that we have tested so far. And we know that immediately one night of good sleep will make everything better. One night will make everything, a bad night will make everything worse. So just really kind of put that to the forefront of your kind of resolutions for self-improvement is to focus on your sleep, because it will make everything better if you can get it.
Yeah.
Agree.
I love that.
Yeah.
That
I do too. That's a great point.
Response. Yeah.
Oh, well, thank you so much again for being here with us today. We've truly appreciated it. Grateful for your time. And obviously, like we said, you've so much information out there. So hopefully somebody listening to this will take it to heart and, maybe come see you.
Yeah. I might have to come see you.
I'll be happy to see you and help you out the best I can. And,
awesome.
And I definitely thank you for the opportunity to speak. This has been an honor and my first podcast ever. So,
yay.
And the first male on your project.
Yeah, I mean, it's a monumental day, really.
Yeah, it's a win-win.
Well, thank you very much. I appreciate it.
Yeah, thank you so much. Bye.
Bye.
The information that you hear on this podcast is not a substitute for medical advice. As always, please seek out personal care and advice from your medical team.